hospital beds, all those dying, frail, old people, all those people with terminal diseases, they're not individuals anymore really, they're machines. And with that, ladies and gentlemen, we propose today that we would like to legalize physician-assisted suicide, and we would like this to be done in the following manner. Firstly, we'll limit this to terminally ill patients. We think terminally ill will be defined by the doctors, and I'll talk about some of the logistics of that. How do we propose to do this? There are two sorts of physician assisted suicide: active, passive. Passive would be withdrawal of drugs. Active would be active, giving of any sort of drugs to kill the patient. We think both will be suitable under our model. We don't have any problems with any of those. We think third thing would be a sort of counselling, not only for the patient, but for the patient's family to deal with the loss, or really to decide, quite frankly, as to whether this is the appropriate measure. And fourthly, the involvement of an ethical board. The ethical board will comprise of a social worker as well, who will go through the patient's personal history, financial history, to see that the decision is not made under the conditions of financial duress, or that there are other conflict of interest within the family that will make the patient more likely to sign up for euthanasia. So we all grounds covered. We think if the decision is made, then the decision is final, then and the patient will undergo euthanasia as per prescribed by the doctor. Now, I'm going to answer 3 questions in my speech, ladies and gentlemen. I'm going to answer the first thing, why there's a need for it. Secondly, I'm going to answer the question, why is it ethical? And thirdly, I'm going to tell you why it's not just ethical, but it's important, ladies and gentlemen, very important that we uphold the right of these individuals for them to be able, quite frankly, sign up for this program. Firstly, the need for it. I haven't started really. I haven't put on my pants. I have the need for it. Firstly, these conditions are unbearably painful. Anyone who has any family members who have been dying from any terminal diseases will know the degree of pain. And quite frankly, Mr. Speaker, that the choice these individuals have is between unconscious sedation and conscious pain, which is ridiculous and inhumane as an individual for us to allow these individuals to continue and prolong their lives with the technology that we have in the hospitals. I think that's inhumane. Secondly, ladies and gentlemen, is that these individuals are terminally ill. They have no hope. Now you may argue then, surely somewhere there might be miracle cures. Now if indeed there are opportunities for experimental drugs and all that, we think we will advise the patient, given the ethical board and the doctors who are involved in the counselling, we will advise the patient on the sort of alternatives available. But really, Mr. Speaker, there is really no grey area sometimes on the sort of conditions that are properly terminally ill. If you have stage 4 widespread disseminated cancer, it's very unlikely, even if you do have some sort of drug that can shrink the size of your tumors, that you're going to survive anything beyond 6 months, frankly. So under these conditions, especially because it's especially painful, we think it's not a grey area at all for physicians to decide that these individuals that can choose, therefore, to end their lives. And third reason I have, ladies and gentlemen, is the unbearable cost, ladies and gentlemen, of palliation. Now we talk about palliation a lot, and they'll talk about palliation too. They'll tell you that, you know what, we have an opportunity here to palliate these individuals. What they won't tell you, ladies and gentlemen, that is palliation is not free. In fact, palliation is one of the most expensive things, quite frankly, because it's chronic, ladies and gentlemen. And who pays for this? Now, make it very clear, if there is a financial incentive for, financial imperative for these individuals to commit suicide, then the medical social worker under our paradigm will find that out, and appropriate counselling will be made. But if there is no financial imperative and really is an unbearable cost to the patient and to the system, then we think it's unfair, not only to the patient but to the other patients who come at the expense, who can be treated for acute illnesses but because their resources are being spent on keeping these chronic patients alive. But ladies and gentlemen, now that's the reason that we need euthanasia, that we need it in our system. But why is it ethical? Firstly, ladies and gentlemen, we have the right to die. Now, they'll argue, no we don't. We don't allow suicide, but here's the difference. The difference is we have the right to die from any disease. Any of you now today with any disease, for example diabetes, have the right to not take your drugs and die from it. If you can die from a chronic illness with not taking drugs, why not these people with more acute illnesses who can die in the short term? Why are we treating them a different standard? If we can die with any given disease, for example, then these individuals should be allowed to die from the disease as well. The crucial difference, they're not dying from attempted suicide, they're dying from their disease, which is an important distinction here, ladies and gentlemen. But more than that, we think it's ethical also because there's informed consent. Informed consent because these individuals are properly aware of what they're signing up for. Properly aware, and because of the sort of services that we provide, the consent that we take, and the counselling that we give. But before that, maybe perhaps you have to challenge.
Sir, tell me who is going to give consent, the patient themselves or the family members itself? And also in cases when patients are coma, right, who is going to be consent, the family members or the patient?
Okay, most of these patients have a pre-directive already, but in the case that we don't, then the ethical board will convene to see the circumstances under which the decision can be made. It could be made by a family member if there was a directive for the family members to take charge during the patient's inability to assume control. But the important thing here is this. There's a Mental Capacity Act. It states that even if the patient is under duress, it doesn't give us the right to withhold their right to autonomy, ladies and gentlemen. Sure, the thing is, if they are legally or psychiatrically diagnosed with a condition that makes them eligible therefore or ineligible therefore for this thing, and we will be more than glad to say no. But if they are eligible, then we cannot say that you're not under the right state of mind. Who are we to decide, ladies and gentlemen? They still have the autonomy. But more than that, the idea that we are inflicting harm, is this ethical? The idea of inflicting harm on this patient, we say yes, because to define harm as being pain and death is really very simplistic. We routinely inflict pain on patients for reasons for diagnosis and all that. The thing is, we have to define harm as more than just the physical pain or death of the patient. We have to define harm as the long-term goals of the patients, the wishes of the patients, the dignity of the patients, in which case, therefore, Mr. Speaker, we think it's not harm, ladies and gentlemen. It's definitely not harm. But more than that, why is it the definite right for us to go so far as to protect their right to a death? Ladies and gentlemen, we here are upholding sanctity of life more than they are. To respect sanctity of life, you must respect the sanctity of death. And we say so for several reasons. These individuals are not only vulnerable, sure they're vulnerable, but they're vulnerable because they're degraded. Because a lot of these patients are not listened to. They're dying in the hospital and there's no one, quite frankly, in the current system who allow them to choose their course of medical action. And we think that is very, very degrading, ladies and gentlemen. We think we have to respect their last wishes. And we respect the last wishes of everyone who's going to die. Even in the prison, when you're going to convict someone and you're going to hang them, we do fulfill their last wishes. Why not do this for these patients here who are dying in hospitals anyways? But more than that, we think that these individuals who will be dying, ladies and gentlemen, and you probably be one of them as well, and in your career you'll be a distinguished individual known for a lot of things. But one thing you will not be one to be remembered for, ladies and gentlemen, is the fragile, vulnerable state of not being able to decide what your further course of action is. When your decisions are made by the people around you because they have no respect to your dignity of life, ladies and gentlemen, I think that is pathetic. For that, we should allow these individuals to choose to end their lives, ladies and gentlemen. Please.
For 7 minutes and 14 seconds.
Thank you. I would like to call upon the leader of opposition, Fatimah Zahra, to open up the opposition case. Here.
Hello, can everybody hear me clearly?
Yes.
Mr. Speaker, before anything, we, the opposition bench, would like to affirm the stance that we believe in the sanctity of life. We believe in achieving self-actualization in people, and we believe that there is always hope, and we believe in dying with dignity. But before that, right, let me just clarify to you that my rebuttals will be largely incorporated into my substantive, right, on the idea of how we differ on the characterization of patients itself, and how there's a situation in a mechanism which is consistent throughout all situations, and also on the idea of consent and suicide itself, right? So I believe that there's direct clashes to our substantive, right? So before anything, right, we question how the mechanism is inconsistent with the principle itself, right? Yes, they would allow for the patients to actually give consent towards forwarding this situation, right? But in cases of coma, like how my whip has POI, that they would allow a third party, an ethical board, to actually do this. So the transfer of responsibility to actually decide this is transferred to somebody else, a third party. So how do you justify that? Why is this even? Why should they be allowed to have this authority to do so? So the autonomy, the idea of autonomy itself is inconsistent within their own mechanism itself, right? So on the idea of state of patients, right, which group of patients are more likely to choose this kind of law to end their life in this way, right? We believe that it's those who feel that there is no point in living anymore, right? Like how they are depressed, they feel the sense of hopelessness, helplessness. There's no point in living anymore. They're so depressed that they feel that the only thing they can do now is suffer in pain, right? But then what we under the status quo have already been providing, right, is palliative care itself, right? Yes, it has put forwarded by the Prime Minister himself, but he did not push further, did not tell you what the status quo is actually doing, right? Why the palliative care exists in the first place, right? All these services under the status quo actually provide an opportunity to end their life as dignified as possible, right? Even though there is no chance of cure, I mean, the only thing they can do now is actually, spend their lives as best as possible, optimize the last few moments of their life, and this is what the government is pushing for, right? Yes, we believe that this negative state, this negative psychological state, will also influence the quality of the choice they will make in agreeing to this proposal, right? Their negative state of mind won't qualify the decision as an informed choice, because their state of mind is only they only see a dead end to the situation and will obviously opt for this kind of proposal, right? So at the end of the day, that they don't have hope. We need itself, depression is also classified as a disease, something that should be treated, right? So